Good afternoon, everyone, and welcome to Pulmonary Grand Rounds. I have the pleasure of introducing Dr. Geoff Chupp this afternoon, who will be speaking to us today about the characteristics and treatment of severe asthma. The CME code is on the board. It's 40599. Dr. Chupp completed his internal medicine training at Tufts, followed by fellowship at BU, prior to starting his career at Yale 26 years ago. And over the course of his career, he's become a world-renowned expert in the management of asthma. He founded the Yale Center for Asthma and Airway Disease in 2000 and currently serves as the co-director of YCAD. He developed an NIH-funded translational research program where he worked to identify novel subtypes of asthma. And he's additionally served as the Yale PI on over 40 clinical trials, testing different asthma therapeutics, observational studies, and investigator-initiated translational research projects. These research efforts have resulted in close to 150 publications. And he continues to mentor fellows and faculty in their research efforts today. So I'm looking forward to what I know will be an exciting talk from Dr. Chupp this afternoon. So please welcome him.
Thank you very much, Sandy. It's been quite a journey, and I'm still standing, and it's been a lot of fun. And I'm going to talk a bit about severe asthma today, a topic I don't really talk about much, but I will tell you that, in preparing this, I did a lot of reminiscing about the 27 years or 26 years that I've been here, and some of us in the room, and have been thinking about it a bit. And I think, as some of you know, when I came here actually and looked at this program, here are the CME, the credits. This used to be called State Chest. And I realized recently a lot of people actually don't know that in the section now. And back then, it was a conference where all of the physicians from around the state who were pulmonologists would come every Wednesday. It was at this time on Wednesday. That's never changed, in this room. And they would present cases. Each of the hospitals would be in charge of a conference. And then the fellows would come in and the faculty would present cases, or fellows, and then we'd ask questions to the group, and it was very, very interactive. And we love that, right? And it's changed a lot. I think it's become a lot more didactic than it used to be. So I'm hoping that this talk will be a little bit more interactive and more of a conversation, because I'm going to present to you guys a case, and I want us to all have a chance to talk about it. And those of you who are online, I don't know, where do I see, if I could see how many people are on somewhere? 35, okay. That open up the mics and speak up so we can have a chat. The other thing I want to say is, as I was been reminiscing about the number of talks I've done, how many I've done this, I've realized that I've given over 5 state chests, and that, I think that was thinking that this is a lot like Saturday Night Live, where, I'm not a comedian, so I could tell this joke is panning already, but that Naftali really should create some new swag and come up with some jackets for people with, the number 5 on them. So after you've been here long enough, you can get your jacket. So just making a plug. All right. So here's the case history. We're starting with a young woman. She's 20 years old, history of childhood asthma, multiple hospital admissions as a child, and prednisone tapers, never intubated, moved to Pennsylvania, from Pennsylvania to Connecticut 5 months ago to be with her newborn and her mother. She's prior to this history, when she was seen in the ER, she'd been hospitalized at Yale like several times in the last year. It had been 3 step-down admissions, was seen in our center, I think for the first time a month or 2 before this, or a few times, and was started on benralizumab. And we'll get a little bit more into that. Increasing asthma symptoms 5 days ago, wheezing, cough, mucus production, shortness of breath. She had been seen in the ER the day before and discharged on albuterol nebs. I think she was maybe given a dose of prednisone and she acutely worsened and came back to the ER. She's been only using albuterol inhaler. She didn't fill prescriptions. She's been given, I think, 1 dose of benralizumab at this time, like within a couple of weeks. She's been using it excessively for the last 6 weeks. She smokes cannabis daily in the form of blunts. And I know what that is because I have children. Yeah, no. Okay, Margaret. All right. So known triggers, weather, humidity, cats, exercise. So this was her lung function at some point prior to admission. You can see she has an FEV1 of 80% of predicted, no bronchodilator response really, and ratios relatively normal. Lung volumes are normal. DLCOs 88% of predicted, and her FeNO is 99 parts per billion. So as you know, that's elevated. That's above 50 parts per billion is really considered elevated. 25 to 50 is kind of borderline by most criteria. We use 25 for the most part. So basically, here's a patient who's allergic and has some evidence of eosinophils based on the fact that she's on an anti-eosinophil drug and her FeNO is elevated, but she's relatively severe now in terms of her symptoms, and she's only been using albuterol, and she's been in and out of the step-down unit. So based on our current guidelines here, and you can see the GINA guidelines, she's nowhere near it at all, right? And I think it's important just to recognize that, as you'll see, there's a fair number of patients around like this, and it's really something we need to focus on. So just getting at the definitions here, severe asthma definitions by the ERS and ATS are listed here. And as you can see on the left, this is kind of our working clinical definition. Not a biomarker or phenotype definition, but what you could see here, that the way we define it is people who basically on the amount of medication you need, which is that if you're on high doses of inhaled steroids and you're controlled, or you're using systemic steroids for 50% of the year or more and you're controlled, or you're uncontrolled despite those therapies. Now, she doesn't really fit the severe asthma definition at this point in time. Because she's not really using any controller, right? So this may be all lack of compliance or things like that, but she does reach the definition on the right, and then some, right? So she's very, by any definition, definitely uncontrolled, right? She has very poor symptom control. She's having frequent exacerbations, and she's had 2 or more requiring systemic steroids. And she's had multiple severe exacerbations that have required her to be in an ICU. Her lung function's actually pretty good right now. And that's even on a biologic therapy, but that is something that I think can mislead you, thinking that this patient is mild disease when in fact they actually could have very severe disease. The prevalence of these patients who are severe is, as you could see there, we consider that to be generally 5% or so of, the asthmatics of patients who have asthma. But again, she really fits into probably a fairly common group of patient that we see in the hospital who maybe has very controllable disease, but is generally very poorly controlled because of her environmental issues and access to medications and things like that. So I guess my first question to the group is this: what concerns you the most about this patient? What outcome would bother you the most, or what would you fear for her in her future? And don't be, well, death, right? That's really
she doesn't understand how severe, right?
Right. So this is a real issue. death is a real issue here for this kind of patient. And we don't really think about asthma as much as we used to as a lethal disease, but this kind of patient has major markers for a really bad outcome, right? And she's very young. She's been hospitalized in our step-down unit multiple times. So why is it that we haven't really been so concerned about it, right? So I think this kind of highlights that a bit, and it tells us a journey I'm sure Lauren and Mark remember very well back when we started in our field in the mid-90s. We were really in the midst of the asthma epidemic, and here you can see the death rate from asthma. And actually, if you go back before this, it's even higher. It peaked right around 1997, right when, you know, we started here. And what you can see here is that there's been this steady decrease in mortality rate for the last, you know, 2 decades. And what's kind of interesting here is that you can see the development of drugs and how that's probably had an impact on that mortality. Combination therapies were really just developed in 2000. That's when the first fluticasone salmeterol inhaler came out. And that took a while to get implemented because there was some data that patients actually had increased mortality from using that drug because they were concerned about beta receptor downregulation. And so there were a couple of studies that had come out that showed increased mortality rate. But then you can see here the first biologic therapy, omalizumab, in 2004, and then this kind of steady drop here. And then, of course, you see here in 2016, 4 more biologics in that last 6 years kind of hit the market, so that we now have 6 biologic drugs against different biologic targets. I'm not going to go into those into a lot of detail. And then, of course, you see our pandemic blip here back up with some of these patients obviously probably having COVID and dying of combined COVID as well as asthma. So how are we doing in our state? Well, you actually can look at this data in 2008 to 16. This is actually IQVIA claims database, a project I worked on with Gene Bleeker. And here we were actually mapping asthma mortality. You could get it down to the county with these large databases. So it was like 12 million captured lives, or more than that, but about 4 million asthma patients. You actually could define mortality. And you could see here in this period of time, 2008 to 2016, we actually were in one of the higher deciles. These are all by deciles. So the darker the color, the higher the decile. We actually had a pretty high mortality rate in 2016, to the point that I think somewhere around 2018 or so, there was the Asthma Foundation of America came out with a report called The Worst Asthma Cities in the Country, and we were number 5, okay? And well, we'll get to that, yeah, thank you. We'll say, we'll see, right? We'll have to see what happens to this case. So anyway, this is the state. We've done better now. Okay, so this is 2021. You can see here, actually, this is from, I think it's from the CDC. It's pulled at this site called Statista. And you can see all of the mortality rates in our country by million. And you can see we're actually doing pretty well right now. So we've improved from 2018 to now, down to, you know, being one of the better states in our union in terms of mortality rates. So, any questions about that or thoughts? Kentucky. Yeah, you mean why is Kentucky doing so well? Well, why do you think? They all have COPD. No, no. Yeah, there's got to be a reporting issue there, right? So, yeah.
I'm not sure when this case is from, but.
This is this year. Yeah.
So I know that
There's been some recent papers suggesting that we should just be giving combined steroid bronchodilators. And I'm wondering if I were to see a patient like this right now, where I'd say, let's just stop prescribing albuterol and just give her something like a Symbicort to be used PRN. Do you
Yeah.
think that that would make a difference if we move in that direction?
I mean, that's a fantastic point, and I'm not going into guidelines, and this is what Sandy's working on, but as you can see now, there's a preferred approach to treatment that all patients should be receiving a low-dose ICS bronchodilator, and generally in the form of formoterol. So think about how far we've come, right? From 25 years ago, where we were concerned that ICS LABA could kill people, right? That there was a higher risk of mortality, to now every patient should be on that, regardless of their severity, right? It's dramatic. So there are now short-acting ICS albuterol combinations in the form of AirSupra, which is recently approved. This would obviously be these kinds of patients would be perfect for this, right? Sandy, I think that, of course, we would all want to make sure they're on that, right? But there's such a culture about albuterol that this has been difficult to implement. So, yeah, yes. Oh, you're waiting.
So one of the things that was interesting about that patient is that they got benralizumab without getting the ICS.
Yeah, well, I'm sure there was an access issue.
Yeah.
I don't know, some states you can't even get the biologic, if you're not filling ICS LABA prescriptions. I'm not, at this point, I was just in the chart. I don't know exactly what the basis of her not being on controller inhalers is, but that's how she arrived at the ER.
Yeah, because
And
so
that was her
interesting. I always
history.
think that you have to go through all
Yeah.
of those steps to get there.
Well, we're pretty successful at getting biologics, especially for patients who have, husky. The best insurance to have here, you need a biologic in this state is really, husky, is Medicaid. So, and some people have argued this is actually a way of dealing with noncompliance. But of course, it wasn't enough to keep this patient out of the hospital, right, at this point.
So we just have a comment in the chat from Carrie Redlick. So asthma rates in Connecticut are very heterogeneous, with Hartford, New Haven, and Bridgeport having much higher rates than well-to-do areas.
Yes, absolutely. Absolutely. So, the accepted paradigm here is that if you have patients like this who are chronically inflamed, flaring, that they get irreversible remodeling of their lung. This is what we call remodeling. And this drives more severity and, eventually low lung function, worse outcomes. And we know that the risk of having a future exacerbation or a hospital admission is having one prior. So this patient is really at risk, not just of death, but if this continues in long-term poor outcomes. So looking at the patient's lung, this is a CAT scan I like to show on the right of a patient with refractory asthma, very low FEV1 in the 50% range, a normal lung CT scan on the left for comparison. And you can see here these thickened round airways that are really consistent with, in medium-sized airways driving this obstruction and airflow limitation. And this is a slide that Rob Homer gave us. I think Lauren showed this recently at her grand rounds. This is not this patient, but this is a 15-year-old who died in the shoreline of sudden death in her driveway, who had, as you could see, the classic features of fatal asthma that we'll talk about a little bit more, but you can see here this, what I like to call the angry airway, with these mucus plug in the distal airway, with these large bundles of smooth muscle hyperplasia, goblet cell hyperplasia that's producing all this mucus. And here on high power, this is a sputum sample, you could see sheets of eosinophils, and you could see them in the high power view as well. So this is really the kind of thing that will go unchecked and put this patient at risk. Now, this has been known about for a long time. And if you go back into the literature, it's amazing what you can find online now. This is 1922. This is the pathology of bronchial asthma. This is really the first description of the medium to small sized airway wall thickening associated with fatal asthma. That was published in the Archives of Internal Medicine. And you can see here this very nice description of airway wall, lumen diameter versus outside versus inside, and showing that it was these medium-sized airways. Now, the other thing that's really evolved, and this is a autopsy study from Canada, was that in these patients who die from asthma, what you're seeing is this smooth muscle hyperplasia, which generally is in these small airways, actually migrates up the larger airways and putting the patient at risk of more obstruction. So when you drive this inflammation chronically, you can not just cause the airways to be narrowed, but you actually change the whole structure of the lung, and you increase your muscle mass into larger airways that puts the patient at more risk. Now, this generally, I'd say, is fatal asthma. And we talk about remodeling and airway obstruction as this process that can occur, and maybe we can slow it down, but there also may be this more sudden type of death related to asthma. And this was very hot topic in the 90s because we see 6,000 people a year dying from asthma as opposed to 3,000 now. And we believe that there might be this subtype. And this is a really interesting study. Prescott Woodruff, he's probably a fellow at the time he did this, with Carlos Carmego, who was at Mass General, ER physician, looked at this large database from Mass General that they had, over 500 patients, and they subtyped them into sudden onset versus slow onset of symptoms. And actually we're able to see, based on their histories, there were some differences, primarily that the sudden onset patients didn't really have any obvious trigger. They would just suddenly just crash. And that's kind of what happened to that patient. The autopsy specimen I'd show. The young woman had been sick for a couple days with a URI, went to her primary physician to get checked. Everything seemed okay. And then, boom, she collapsed. But from the mid-2000s, early 2000s, there really is no literature about sudden asphyxic asthma. It's not really talked about anymore. And I'll show you a little more data from Jose and another one of the people we work with, Anita Wang, showing there could be some biologic basis for people being at risk of dying. All right. Any other questions, thoughts at this point? Yeah.
So, Geoff, I'm right here, so is it on?
Okay.
I just wonder, are you going to also walk us through the phenotypes that we're seeing in older individuals with the sort of second peak prevalence? And what do we think about the airway remodeling in those patients?
Yeah, I'm not.
Okay.
No, I can't. I could. I don't have it in here. It's a great question. I mean, obviously, I think that you'll see the patients that have had this kind of severity with us. I do adult onset severe disease. We generally don't see a lot of intubations in that group. I think there's a lot of reasons for that. They tend to be probably more compliant with medications. So they're not things aren't ongoing, but they can get severe obstruction and things like that. So
So
I'm not
Geoff,
really going to go into detail about it.
Just
Yeah.
one, getting back to the sudden asphyxic asthma comment and a question. So, I've seen patients in the ICU where the story you initially get is that they were fine and then they ended up intubated.
Yeah,
And then when you actually talk to them,
right.
you realize that they actually became used to being symptomatic and impaired
Yeah,
and had very poor exercise tolerance and other things.
yeah,
And so it wasn't really sudden.
right.
And so I'm wondering, when you try to categorize these patients, to what extent can you ever really be sure
Yeah,
that somebody's truly well and then
yeah.
clamps down?
Yeah, I think there's definitely, I think that's a huge issue, of course. I think that some of these patients, so the way that Prescott subtyped these was by 3 hours, more or less than 3 hours of onset of symptoms. You don't know where they started from, I guess is what you're saying. And I think that's obviously a really good point. But I do think there are patients that seem to be much more prone to severe events than others. So I do believe there's some biologic features to it. Yeah,
There was a story in the 90s that people who had, some of the people who had acute sudden onset asphyxic asthma had poor sense, as Mark said, of their set point. There was a whole
Yeah.
literature about
the
that.
poor perceivers.
Yes, the perceivers, and that was the reason.
Yeah, that's right. And we don't really talk about that anymore like we used to, right? I think it's just because the whole landscape's changed. The diseases have, evolved because of all the treatments we have now. And so we don't think about it the same way. So let's get back to our case. Good comments. This is exactly what I was hoping for. So physical exam. So patient's heart rate was 130s to 150s. O2 sat was 95% on room air. Blood pressure was 140/90. Respiratory rate was 33. Moderate distress, diffuse wheezing. Was able to speak. Got Solumedrol 125, continuous nebs, terbutaline, IV mag, and blood gas was 732/40, 122/98. So COVID, RVP negative. RAST was, went back just to give you some history. She's positive for everything, like very positive. 23-hour aeroallergens. ANCA, MPO, PR3 were negative. She had an IgE level of almost 3,000, and her blood EOs were 0. So my just quick question for the peanut gallery, why her blood EOs 0? Because she's been treated, right? Okay. Here's her chest x-ray. At the time of admission into the ER, you can see there's really nothing on her chest x-ray. A little hyperinflated probably, but not huge, like it's 10 ribs I counted. I don't think it's, like sometimes you'll see flat diaphragms, right? So she's kind of, but hypolucent, I guess, but no obvious infiltrates. Now, obviously the patient needs to be admitted, but I want to just kind of pivot for a second to talk about this asthma exacerbation care pathway that Sandy has developed with Nancy Kim, which is in Epic. And so it's in the tools tab and you can look at it. It's got a lot of information in it. It's all guideline based and it's very useful actually. And I've been trolling through it and I had to go find it. So just remember it's in the tools tab, like, care pathways. And it's I think it's helpful. But it's, really designed to improve how patients are managed with asthma exacerbations and to kind of just align the management of these patients. So we're all doing the same thing. And I'm not going to go through it in detail. I mean, this is not what we're really here to talk about, but I do want to just mention a couple things. So there's 3 tabs that relate to admission, SICU transfer. So they give you some information about how to decide whether a patient should go to the step down or the ICU. And then discharge education. So how do you make sure the patient's ready for discharge and things like that? And so here you can see the admission issues. So it tells you the severity of disease, mild, moderate exacerbation here. So, fairly mild clinical symptoms, heart rate 120 or less, peak flows are 80%, between 50 and 80%. So we don't do a lot of peak flows here in our hospital, but they're in there because they're part of the guidelines, and so this has to be guideline driven or evidence driven. And then you can see severe needs a higher level of care, moving a little air, hunched over, respiratory rates elevated, heart rates 120 or higher, SATs may or may not be, less than 90%. So any of these criteria kind of puts that patient into the more severe exacerbation group. And then, of course, your severe patient here was impending respiratory failure. And you can see here, there's also, what you should order and give the patient if they haven't had it. And they also have some guidelines here for blood gases. And I think that's the big thing here. These patients need to be, their blood gases need to be checked. And the big story is that we've always said, and that's, you see a normal blood gas like hers, you should be concerned, right? Because usually in an asthma exacerbations, people have a respiratory alkalosis from their work of breathing, right? So you always have to worry about a patient like this patient who had a CO2 of 40 to be a bit concerned. Now, there's also gives you some, ICU transfer options and things like that. And we're not going to go into this, but just to tell you that, it's available there. And I think very good to have something to check on. And then on discharge, of course, I think the big thing here that I wanted to make sure, and one of the reasons, this lecture came up with Jonathan and I was just, making sure that, patients are properly teed up for discharge and that they're ready for that. And because sometimes there's, with all the way within the hospital these days with interest in moving people through the system, you got to make sure, especially in a patient who improves rapidly, that they're tolerating nebulizers every 6 hours or less and things like that. So that's something we used to talk about a lot, but I think that these days, sometimes it can slip through the cracks. So make sure the patient's safe for discharge. So any thoughts about this patient? What do you guys think? I mean, where do you think she should be sent? MICU, okay. So that's based on just overall picture from the way it's presented. Yeah, so let's go back to that.
So I mean, she's 732.
Yeah,
So she's not just.
so why is she, right? So she's got probably a metabolic acidosis, either from continuous nebs or work of breathing, right? So this is something we very well acquainted with over the years, right? And that's concerning, of course. So she was seen, and the decision was made for her to go to step down. So she arrives in and I'm not, I don't think I wasn't there. I don't think this is always a tough call. But she arrives in the step down. She's tripoding, tachypnic, tachycardic to the 150s, using accessory muscles to breathe. ICU fellow at bedside for evaluation. So they knew she wasn't doing well, but they got her up to the step down. Patient was anxious, wheezy lungs, bilaterally, mom at bedside. Here's her blood gas. So a little bit worse, right? So what would you do next? Okay. I mean, we're all Monday morning quarterbacks here. So who would do what? So how many for intubate? All right, we got okay. How many? Wait, so you got to put your hand up high, okay? You got to commit. All right. All right, good. So how many for, what did you say? BiPAP. How many for BiPAP? Okay.
Frequent BiPAP with like Q1 hour ABGs, Q2 hour ABGs, and like, see how she does, give her a chance to fly, might be reasonable.
Okay, so, no, I think this is good. So, all right.
Can I ask a question on that?
Does anybody want to try anything else? Yeah.
Can I ask for clarification, call an expert or friend on this? Because in COPD, there's evidence for a trial of BiPAP, right? But
Right.
is there evidence in like
evidence
the
for-
severe asthma? I don't know.
Yeah, all right. So anything else people would try? Yes.
Is she still on continuous nets or?
Yes, she's still on continuous nets.
Is she on any?
No.
So
like what?
Finbar's asking about continuous nebs. She's still on continuous nebs.
No, she's not on IV mag.
She's not getting IV mag, but she got it in the,
She got IV mag in the ER.
there you go.
Was now I get, she got IV mag in the ER. Heliox. Okay, excellent. All right, Heliox. Anybody for Heliox? Okay. So. Well, we used to use a lot of Heliox, right? Yeah. All right. So let's talk about Heliox for a second. All right. So Heliox is an option. We have used it with success, I think, in individual cases. And as you know, it reduces the turbulence. It's not a dense gas. When you give it to people who have airway obstruction, especially primarily large airway obstruction, right? Vocal cord paralysis or a tumor in the airway, in the trachea, it reduces the work of breathing because it's better, more laminar flow because it's less dense. There's a few, we almost did a trial on this here in the ER. We had, I think, a resident who was going to do it, but he moved on. But if you look at the data, and this is a Cochrane review, you can see here that the data's pretty poor in asthma. Smaller airways that are generally obstructed, so you don't really have that much effect on turbulence. And when you look at all the different trials that have been done in the ER, so these are ER setting trials, you can see here that the overall outcomes, are not better than the control. So, I don't think it would hurt to try it, especially if you can get it quickly. And respiratory usually can grab it. They have to get a tank. It's usually 30-70, 30% oxygen, 70% helium. And then they increase the oxygen. They have 40-60, but anything higher than that in terms of oxygen, you lose the benefit of the lower density. So there you have that. And so if you could try it, but it's probably not going to work. What about BiPAP? So there's also a nice study here. This is from the Colorado group looking at this. This was published a couple of years ago, actually showing that looking at multiple, this is actually a very large claims database that they have access to. Over 100,000 patients, multiple centers around the country. And what you can see here, when they look at multiple outcomes here, there was patients who were 12,000, they were matched by propensity of severity of illness, 12,000 in each group. In all models, you can see BiPAP improved outcomes compared to control, and including need for mechanical ventilation, okay, and death. So there was some benefit. So, Jana, there you go. You got it. Yeah. Now, it hasn't been looked at prospectively,
Yeah, no,
but I think this is pretty compelling data.
I actually think if Jana's sitting by the bedside watching very carefully, that things are going to be okay. But I think it's important because the same thing comes up in the COPD literature and is often misinterpreted, that it's BiPAP versus usual care, not BiPAP versus intubation. And so,
Right.
the issue is, are you going to just keep her on the continuous nebs versus try non-invasive? But I don't think that the study is looking at, should I intubate or try BiPAP?
Yeah.
It's a different question.
Well, that's right. I think that that's true. So I agree with that. But I guess the point is that BiPAP, I don't think you're going to hurt the patient with BiPAP as long as you do it right.
Yeah, as long as
And
you
I
don't
think
walk away.
that's your point too. And in here, the good news is the patient has to be in the MICU to get BiPAP, right? So this patient would have to be transferred. But
You're really trying to offset the work of breathing and support the respiratory work while you're waiting for the other medications to help break the tight airway obstruction, and if your time is favorable in doing that and it's helping her enough
yeah,
and you're watching her really closely, it could be okay, but otherwise may not be.
yeah. So yeah, the retrospectoscope, the timing of when, so should have been in the ER is what you're saying. And I think that the patient was evaluated in the ER by an attending and a MICU attending, and I think at the time felt the patient was actually pretty stable. I think the patient deteriorated between the time the patient was seen in the ER and got worse, and because she was speaking and didn't look as sick, and so they didn't think the patient needed BiPAP or the MICU at that point in time. But yeah, very good point as well. So let's see what happened. So patient was transferred to the MICU on BiPAP, 12/5, evaluated about an hour later, noted to be diaphoretic, tachypnic, tripoding, respiratory distress, pulling off BiPAP mask, holding it off her face, stating she could not breathe, appeared very anxious, verbal redirection was attempted, blood gas, 71762, 433. So obviously she needs to be intubated now, right? Worse decision was made to intubate, anesthesia performed, rapid sequence intubation, placed on fentanyl and propofol drip for sedation, initially volume AC, very tough, desynchronous with event, transition to pressure control. Patient was started on paralysis, put on PRVC. All right, any comments, thoughts? Well, that's the note in the chart. I mean, I don't.
That's the whole caveat with them going to the ICU on the BiPAP. You have to be on.
Yeah. Yeah, you have to check another blood gas in 20 minutes, right, on the BiPAP.
So Jan is
if
just
you're-
commenting, maybe we should have checked on the patient before an hour.
Yeah,
in
yeah,
the
no, no,
NICU.
I agree.
We have to repeat everything. Sorry.
Oh,
So people on
sorry.
Zoom here.
I'm really bad at that. All right.
It's scary to intubate these patients.
Right.
Yeah, Murdo's just talking about how it is difficult to intubate these people in the ED as well and manage the vent from the ED.
Comment about the BiPAP, and one of the reasons that, just for the sake of furthering that thought, in the COPD population, if the underlying condition in particular is emphysema, where there may be sort of overly compliant lungs, the pressure that one usually requires of a BiPAP is not necessarily as high as one might need in the tight asthma exacerbation situation. And so to some degree, the success of BiPAP is likely to be related to not only tolerance for a mask and whether it's offsetting the work of breathing and improving gas exchange, but what high level of pressures do you need to be able to ventilate the patient at all? And in the face of very, very, very tight bronchoconstriction and airflow obstruction, you may need higher pressures than the patient can tolerate it. And that's a little bit less likely to be the case in the COPD population.
I think that's a great point. So Carly just said that there's a big difference between ventilating somebody with BiPAP with COPD, where compliance of the lung is very high, versus a patient with asthma, where the primary abnormality is inflammation of the airway and mucus and bronchospasm. And so your pressure requirements with BiPAP may be very high. And so you may be unlikely to be successful. I think that actually speaks to the settings that this patient was put on, right? If she's severely obstructed and has a very high level of auto PEEP, 5 of PEEP may not really do anything, right? And so you're not even overcoming the patient's intrinsic auto PEEP, which is one of the potential benefits to reduce her work of breathing, right? Yeah.
Can I comment? This is Jose.
Yes.
Yes. So, I mean, I think one of the challenges that we face with patients like this patient is the issue of dynamic hyperinflation, right? And I think that, typically our patients have such a big drive because, very often they tend to be younger. And obviously that is a pretty big component of this dynamic hyperinflation that, even when they're intubated, it's very difficult to overcome. And again, I think that the challenge also when you have patients with asthma that we know are like tend to be like less sensitive, like have decreased perception of the stress, right? Typically gives you a false sense of security in the sense that some of these patients may seem okay when the resistance in their airways is pretty high, like the load is pretty high compared to somebody that at the same load will be very, very distant, right? So those are many kind of like unique things about the asthmatic that make it, pretty distinct from some of the other patients that we're more used to, like, like COPDers on BiPAP or heart failure on BiPAP. So definitely, again, it's just a little bit more complex, looks very, very different. And it just takes exposure to seeing some of these patients sometimes so you can anticipate some of these changes, right?
Yeah. Very good point. I mean, I definitely think that these young patients can be deceiving because they can tolerate a lot of illness really well, So this just kind of highlights a little bit what Jose was talking about, which is you can see this is dynamic hyperinflation that occurs in these patients. They air trap because of the inflammation and bronchospasm. They increase their respiratory rate, and they end up, developing dynamic hyperinflation. And we sometimes used to call that breath stacking or, but it's auto PEEP. But essentially what happens is it makes it harder for them to breathe, and eventually they develop hypercarbia and arrest. You can see here too, I'm not going to talk about all the mechanical ventilation pieces here, but the important thing is just to make sure that you understand that the issue here with these patients is that you're trying, when you ventilate them, and you can do it in a number of ways, you're trying to reduce barotrauma and hypotension, really. And we used to say, generally, I think we've moved to the ARDS type world in terms of what's considered okay for a plateau pressure. We used to talk about mean airway pressures and things like that. But now I think it's kind of accepted is a plateau pressure less than 30 is really your goal. And if you're above that, your risk of barotrauma is higher. And we used to see patients with barotrauma all the time and put chest tubes in them. And we just really don't see that much anymore because I think we've improved how we ventilate people. Pressure modes are often used. You want to limit the minute ventilation, low tidal volume and respiratory rate to allow expiratory time so that the patients can empty and move towards permissive hypercapnia. We used to use bicarb drips on these people, keep their pH up. And there's a big, the most recent review actually in the literature that I found was from 10 years ago. So we don't really see a lot of this in the literature these days, but some people have different ideas about how to set PEEP in these patients. Some people believe you should have no PEEP, but my education was always you should set your PEEP at about 80% of your measured auto PEEP. You shouldn't match it, but you should be somewhere near that. I think you can do a best PEEP curve, you can, if you follow the patient carefully and you can test it out and see if it changes their tidal volume, you could improve that, but that's just kind of some general rules. So, yeah. And just to say, we do, sorry, one last thing. So they used to do apnea maneuvers here where to measure the volume, give a long exhalation time and measure that volume on patients. But now, as you all know, I think end expiratory holds to measure auto PEEP. But just remember, you don't measure every airway necessarily because the airway is very heterogeneous, the lung is, and some of those airways will be completely plugged versus others. So what you're measuring is what is accessible to the mouth, to the end of the mouthpiece.
Yeah,
Yes.
I think that's also important when you talk about the plateau pressures that you're measuring, right? Because you're only measuring the ones that communicate with the airway opening. And with respect to the PEEP, I think it all comes down to whether you make hyperinflation better or worse with it, right? So if you're impeding exhalation, then you may make it worse. But the idea with the PEEP would be that you might make the airways a little bit larger.
Yeah.
And actually allow better exhalation.
Right.
But it has to be completely empiric.
Right,
right?
because
Let's say,
every
like,
patient's disease is different. And in some of these people, and they're definitely some may be more prone to over peeping, is what you're getting at, right? Depending on the distribution of their obstruction, right? So something you have to just look at it in every patient. Now, patients, I know we're getting close on time here. This is going a lot longer than I thought I was going to. Still very bronchospastic, high auto PEEP, 10 to 12. This is day 2. New attending comes in, actually, and the patient was at St. Raphael's, by the way. Just wanted you to know that because it is kind of relevant. Versed, fentanyl, propofol, rocuronium, solumedrol, ceftriaxone, doxy, a little bit of levofed. MAPS that's not 0.02. MAPS were better than that. 65. Continuous albuterol nebs, tube feeds. PRVC, decreased tidal volume. This is like literally from the notes. Lower tidal volume, monitor ABG, allowing hypercapnia. And then a note comes in the mornings, worsening bronchospasm through the morning, severe air trapping with total PEEP, 12 to 15 range. I think that's auto PEEP probably. Very difficult to ventilate, eventually pH 7.0 to 0.6 range with permissive hypercapnia. PRVC was at 14, 300, 5, 50%, P-plat 28. There's the blood gas. So we did this for years, just like this. And what would we do, Mark? Pray. Yeah. Well, we'd bicarb drip and wait. Yeah. And patient would kind of manage. And almost always, they did fine. You just had to wait.
The doctor didn't do fine. The doctor was scared.
Yeah. Anybody else? So ketamine, I have a ketamine. Have what? Sevoflurane. All right, excellent. Anything else? ECMO. All right, let's get this done. Okay, ketamine, number 1. So has been looked at, all case reports as far as I can tell, has some benefit. They show here improving CO2s somewhat, doesn't last that long. They get worse again, it sounds like. I have not had success with it. I mean, be interested to see if anybody else has here. We push 10 milligrams at once. I get anesthesia up to do it, but that's a lot. And I haven't really seen it work. So anybody seen it work? Okay, it's in the literature. Sevoflurane, also case series. This is actually 4 cases. We do have some experience here with sevoflurane. I've done it on a couple of patients. I had to get anesthesia up to do it. They didn't like it, but they did it. And then they created a new policy that we're never going to the MICU again for an asthmatic. And so now I think it's even harder to get, but you can get it if you take the patient down to the PACU. And it's a very effective bronchodilator. And I've seen people's tidal volumes, double within 30 minutes of going on it. So it can definitely work. Yeah, so you keep the patient on it for like 16 hours. And that's why they don't like it, because they have to keep an anesthesia person at the cart while they're there, while they're on it. And they keep them on it usually for overnight is what I've done, or started it like 12 to 24 hours, and then you wean it off. And the patients, I've treated probably 2 patients. One had a dramatic response, I think saved that person and doubled their tidal volumes. And over time, they didn't get worse, after I weaned it off. So it helped them break. What about ECMO? So that's really one of the things we're going to talk about the next 5 minutes. This has been looked at. There's a lot of case reports. There's a number of series on it. The most recent one published in Chest, which was a large retrospective analysis, again, of patients treated with ECMO for severe asthma from 2010 to 2020. And what you can see here was they did a propensity score matching again. Again, it's retrospective, not a perfect trial. But what you can see here is that patients were treated generally pretty quickly after they were in the hospital. So most of them were treated within a couple of days. And here you can see mortality for most endpoints. The propensity matched here were, depending on their patients who had multiple admissions or even one admission, you could see ECMO tended to improve mortality compared to the patients who got ECMO for other reasons. Now, lengths of stay was definitely longer, and as you can see here, cost was significantly higher. Now, what about our experience? You can see here, we've had 4 patients on ECMO in the last couple of years. Or so, you can see that they've generally all done pretty well. ECMO for about that range, they get it anywhere from about 6 to 10 days. Always initiated for severe hypercarbia and acidosis. And they've all been, most of them have been young people who were generally not taking a lot of medication when they came in and had very severe exacerbations. And all of them have been discharged. Now, I'm just going to say one little plug here about biologics, because I did find one article in the literature on using an anti-IL-5 drug, mepolizumab, in a patient on ECMO that actually patients was lavaged multiple times, had eosinophils in their airway, and was given this anti-eosinophilic drug here, mepolizumab, or anti-IL-5 drug. And you could see here the sweep time on the ECMO improved dramatically after they were given the drug. So no literature on using biologics acutely, but we know how potent they are, so there may be certain situations where they could be beneficial.
I was wondering if you could comment on just the issue of trying to clear mucus plugging, which is often one of the things that makes these people who are already sedated on neuromuscular blockade have, and so bronchospastic, still have difficulty ventilating, and just saline lavage and hypertonic saline depths and things like that.
Yeah.
In a case like this.
I mean, we've tried all those things over the years, lidocaine, nebulized magnesium, aminophylline, often put the patient on all these things because it's relatively safe. Bronch is impossible, I think, but yeah, you do what you can. So patient was placed on ECMO. This, I think, was heroic, really, what they did. The patient was put on VV ECMO at St. Raphael's and then transferred on ECMO to the CTICU at Yale. So I think that was amazing, actually, and not an easy thing to do. She was extubated, she improved. They turned her vent settings down, matched the PEEP to her auto PEEP. turned down her minute ventilation, continued the nebs, and as she slowly improved, she was extubated and then decannulated, and she was discharged home. So I'm just going to finish up the case. 2 months later, she came back to the ER. She had PTSD from her experience in the MICU. I think she had another flare. She was still smoking blunts, and she was intubated again and then extubated after a week. She did not go on ECMO, but discharged finally in stable condition. Now I have biology here to show you guys. I'm not going to bore you with that, but this is Jose's work, where Jose actually found, because it's Jose's, he did actually identify a marker of patients who are at risk of severe fatal exacerbations related to YKL-40. But since we're out of time here, I'll just say that this patient is now Jennifer's, who's doing really well. She finally got her life in order, right? She's not smoking anymore. She got switched from benralizumab to dupilumab because she wasn't really responding that well. And you can see here her lung function has improved. Here's at the bottom her most recent numbers. And you look at her exhaled nitric oxide level, which was 99, 200. It's now down to 8. So, you know, it's been a battle for this patient, but she's young and she's now under control and she has a future. So thank you.
So I think we're at like 4:05. If anyone has any questions, feel free to come down. And thank you so much for a really engaging and interactive talk.